Hello everyone, my name is Dr. Ram Khare. I'm a GI laparoscopic and robotic surgeon at Fortis Hospital, Vashi. So this is a fairly difficult case of gallbladder perforation for which laparoscopic cholecystectomy is being done. This 80-year-old morbidly obese male had an history of chest pain and he was admitted for the chest pain. On angiography, he had triple vessel disease. So the relatives and patients were being counseled for the need of CABG. The very next day, he started to have a severe abdominal pain for which the CCT abdomen pelvis was done, which was suggestive of acute cholecystitis with gallbladder perforation and around 200 to 300 cc collection in perihepatic space. So he didn't had classical signs of generalized peritonitis, and he was already started on dual antiplatelets. So firstly, we decided to put a pigtail inside the collection and drain the collection, and then later go ahead with the laparoscopic cholecystectomy. So on diagnostic laparoscopy, as you can see, the pigtail tip is visible, the bile is visible, and the omental cake is there. On primary examination, I couldn't see a liver or a gallbladder. So my plan was to do a lavage first, take down this omentum from the anterior abdominal wall, and then take out the pigtail. On putting my two working ports, firstly I swiped down this omentum, and where I could see the inferior surface of the liver. Still the gallbladder is not visible. So again, after giving a thorough lavage, I firstly started to dissect the pigtail. On delineating the tip of the pigtail was taken out, and further dissection was proceeded. As you can see, now the pigtail tip is taken out. Now here I could see the glimpse of gallbladder fundus, so which I am holding with my left hand instrument. So for further dissection, later I needed a retraction port. So I put a 5 mm retraction port, and here goes my tooth grasper. With the help of tooth grasper, I held the fundus of the gallbladder and pushed it towards the right shoulder, and with both of my instruments I could proceed with the adhesiolysis further. With gentle swiping movements, I could in between suction I could see the other side of the liver, and few adhesions were omental adhesions were divided with the help of monopolar hook cautery. In such kind of cases, traction and counter traction is a very important thing. Now the lateral dissection was over, and further medially I started to do an adhesiolysis. Here I could see the first part of duodenum was dentally stuck on the Kellogg's triangle area. Few remaining adhesions were taken down. Now the gallbladder is completely free of all the adhesions. Now I started with the Kellogg's triangle dissection. With the help of monopolar hook, I am just incising the peritoneum over the Kellogg's area on anterior part and extending this incision towards the liver, so I could see the cystic duct and cystic artery. As you can see, this kind of Kellogg's triangles are always to be opened up with the help of blunt and sharp dissection. Now I am extending this dissection over the cystic duct area and further posteriorly. With the help of suction tip, I am trying to create a window, and here I could see the anterior cystic artery, which was taken care with the help of monopolar hook cautery, and further dissection was proceeded. Now the posterior part of the Kellogg's triangle is being opened up. Firstly, the peritoneum is incised with the help of monopolar hook, and the cystic duct, as you can see, is being skeletonized. Now you can see my window has been safely created. Now further, I wanted to lift the distal 1/3 of the gallbladder from the gallbladder fossa. so any other structures can be swiped away. Here I could see the posterior cystic artery was coagulated with the help of monopolar hook, and my Calot's triangle dissection was completed. Now the next part was to milk the cystic duct. With the help of bowel grasper, I milked the cystic duct and then held it down and applied a Liga 400 clip. After clipping the cystic duct, it was time to cut the cystic duct. Now my Calot's triangle dissection is completed. Now the next part is to lift the gallbladder out of the gallbladder fossa with the help of monopolar hook. Now here also traction and counter traction plays an important role. After completely dissecting the gallbladder away from the gallbladder fossa, the gallbladder specimen was parked inside an endo bag and then later on taken out. After placing the gallbladder and giving thorough lavage, I put a 28 number abdominal drain in a gallbladder fossa and surgery was completed. This patient